So I'm Matt Bajoli, and I work for Advent Health, formerly known as Florida Hospital, here in Florida. My only disclosure is I do some kind of on-again, off-again consulting work for Electa Brachytherapy. So objectives that I wanted to kind of go over today is really just kind of give you an idea of who we are at Advent Health and kind of why we chose the body tome. And then kind of show you how we incorporated the body tome in the rad-onc department originally, and then ultimately, once we built a brachytherapy suite, how we incorporated it there, and then kind of show, our initial workflow versus our current workflow, because, our purchase of the body tome was really a thought process around maximizing efficiency. And then kind of go through some minor differences between CT versus MRI planning, and primarily kind of reviewing some cases. So Advent Health, I would call it a medium-large hospital system. It's 45 hospitals across 9 states. Here in Orlando, where I work, we are basically a network of 8 campuses with about 2,500 beds and about almost the same amount of number of physicians. We treat the largest number of oncological patients of any hospital in Florida, and to kind of put that in perspective, we treat about 2 times the number of cases as Moffitt, just down the street over in Tampa, which is the 3rd largest cancer center in the country. So the way that we work as a network is essentially, we have 14 campuses spanning 6 counties. Our brachytherapy program is primarily based out of the Orlando main campus, where we focus mostly on GYN and GU. We do have 3 other campuses that do some breast IORT, but we only do probably maybe 100, 120 cases a year. We have 22 board certified radiation oncologists, of which 2 are trained here in brachytherapy, and essentially we use the Orlando campus as a hub where we refer in all our brachytherapy. So pretty much for the whole 14 campuses, all the brachytherapy other than the IORT is done here. If you look at our volume, I think this was to date as of September. We did about 600 fractions, which included 135 prostates. We did about 260 intracavitary interstitial GYN, and about another 190 vaginal cylinders, and a handful of endorectal cases. Part of our plan when we took over this department back in really 2015, ultimately was to make an investment in a dedicated brachytherapy suite. And kind of where our vision was to build a self-contained brachytherapy suite where you could put a patient asleep, do the implant, and then while they're on the table, do the simulation. And then our thinking at the time was that, to leave them on the table asleep while they did the planning, do the delivery, and then remove the implant, almost, so that we could work essentially in a more linear fashion, which is kind of a rarity in brachytherapy. And the thought process there was that we could probably do cases in about an hour and a half. But we very quickly realized that having an intraoperative CT capability was really necessary to kind of pull that off. So this is going back to 2015 when we kind of inherited a department that did very little brachytherapy. This is what our initial workflow looked like for our prostate HDRs and most of the GYN implants, where essentially we were doing the implant at an ambulatory care or ambulatory surgery center under ultrasound guidance, and then while they were still asleep, we'd have to essentially transport them down the hall to the department CT simulator, at which time we would scan them, and then depending on the patient, we might also then move them across the hall to the MR simulator, and then, or they just go right to treatment planning, and then we do the treatment delivery, and then implant removal, and then depending on the type of implant, obviously the intracavitaries we would just take out in the clinic, but for the interstitials we would actually take them back to the ambulatory surgical center and do it under MAC. So this is all happening on a single floor, but there was a lot of moving parts and it required a lot of coordination. So this is kind of looking at our initial workflow for vaginal cylinders back then. So we place the applicator essentially in the CT simulator, and then we would have to essentially move the patient off the table and then transfer them to the HDR room at the time. And then, while we did treatment planning, and then we do the delivery, and then obviously the applicator would just be taken out of the room. Why we, in the process of our selection and how we ended up with the body tome, the main driver, I think, was just the need for additional treatment planning simulator to accommodate the growing brachytherapy volume, as we were basically competing for time on a single simulator serving this one department with the external beam patients. How, when we did our initial evaluation at the CT scanners that were out there, how we landed on the body tome, it really is kind of highlighted here. I mean, it has a very large field of view, which is important, especially here in Central Florida, as we do have some larger patients where that would be an issue. It definitely had the largest scan range than anything available. It's a large bore. The gantry is 85 centimeters. It had the strongest tube power out there on the market. It had the ability to do contrasted scans. The tables that were available could handle over 500 pounds and had an independent workstation. So when we purchased the body tome, this is going back in early 2018, that now if you look at our workflow and how we handle the prostate and GYN implants, we were still basically implanting them in this ASC, and then essentially, rather than competing for time on the departmental CT simulator, we just put this in a separate room where we could still simulate them under anesthesia, and then the rest of the process kind of remained the same. And this is actually the Linac room that we initially put it in. We took an old machine out of here. This room had been earmarked for an MR Linac, but there was an issue around the funding. So knowing we were building a brachytherapy suite, we just took opportunity to put it here. But ultimately, our plans was to move forward with a brachytherapy suite, which was in construction at the time. And this is our suite today. So it's not a large room. It's 400 or 500 square feet. And as you can see, we have full anesthesia capabilities. There's the CT compatible table, and you can see the body tome. This is looking at it from both angles. What you can't see in here, which is basically is actually the HDR unit, which it looks like whoever took this photograph is sitting right on top of it. And then just outside that, we have kind of the treatment planning area. And then actually, if you were looking at the treatment planning area from that angle and you kind of look to your right, that's exactly what the holding area would look like, where we kind of pre-op and then recover our own patients. So kind of looking more specifically at GYN brachytherapy, the improvement and sophistication of image guidance has really revolutionized, particularly cervical brachytherapy, particularly with the, adoption of ultrasound for intraoperative imaging to kind of get an optimal implant. And then the movement from using fluoro to CT or MRI based image planning to get optimal 3D dose delivery to target, and spare your organs at risk. Image-guided brachytherapy has been demonstrated by the Vienna group to improve local control, as well as progression-free survival while reducing late toxicities. And the JEC Estro, as I'm sure most of you are familiar with, has formalized image-guided treatment guidelines with MRI, essentially as the gold standard. However, access to MRI simulators for treatment planning is somewhat limited. And if you look particularly in the US, and I'll show you these numbers a little bit later, CT remains the most commonly used image modality for treatment planning for gynecological brachytherapy. This is our, I say current workflow. This is actually more of our pre-COVID workflow. And and the only difference that we've moved from is we now treat these patients BID during COVID, just to try and limit the amount of times they have to come to the hospital, or the amount of times that we have to put them under anesthesia, kind of reduce the risk to the patient as well as reduce the risk to the staff. But essentially, for kind of our intracavitary or hybrid applicators, we'll, on fractions 1 and 3, this would be, before we were treating BID, we would do the applicator insertion under anesthesia. We would then do immediate CT scan on the table with the body tome, and then we would move them across the hall for MR simulation. And then the patient would just they would just bring them back across the hall to recover them in brachy, and then we do treatment planning and delivery, and then subsequently the applicator removal. For the hybrid cases, we still remove those under MAC, but we have full anesthesia support, so that's really helpful. For fractions 2 and 4, pre-COVID, we essentially, weren't using MRI. So essentially, we're placing the applicator, doing the CT scan, and then transporting them over to the PACU, relatively quickly doing the treatment planning, and then bring them back in to do delivery, and then we're removing the applicator. Depending on our caseload and the patient, there are certain patients that we have also basically done the whole thing asleep, wherein, I had a schizophrenic patient the other day that we didn't think was going to tolerate this awake at all. So essentially put her to sleep, placed the applicator, scanned her on the table, left her asleep on the table while we planned it, treated it, took it out, and she wouldn't, she didn't even really know that we did anything. This is our current prostate and our GYN interstitial implant workflow. So, and I'll show you why we will frequently scan patients both with the CT and the MR simulator. But as we implant these patients under ultrasound guidance, we'll scan them with the body tome on the table, and then depending on the patient, they'll either go for MR simulation or they'll go right for treatment planning, treatment delivery, and then we'll remove it under anesthesia. And then this is probably where we've seen some of the most efficiency is with the vaginal cylinders, because now with the brachy suite, for the first fraction, we'll place the applicator, we'll scan them on the table. This is actually a little incorrect. We'll basically leave them on the table while they do the planning, and then treat them, and then remove it for the first fraction. That's why I forgot about that. So that's kind of the difference away from our previous workflow. That whole process takes about 30 minutes. For subsequent treatments, we'll place the applicator, and we really are just using the body tome to do the scout x-rays, and then we'll just treat them and remove it. That usually is a 10 to 15 minute process in total. I'm going to talk a little bit more kind of about imaging with gynecological brachytherapy. As mentioned, we do all our implants under ultrasound, even the intracavitary. It's kind of a little example of like using abdominal ultrasound, which we will on occasion. I think I tend to favor doing transrectal ultrasound just because we tend to have a larger patient population and the resolution is better. But it is nice having the body tome because if there's ever any question, we can just scan the patient while we're doing the implant to make sure that we get an optimal implant. So I just wanted to kind of referencing back to kind of, at least in the US, who's using CT versus MRI. And this is kind of the most recent survey that was done in 2014 by the ABS. And, of the 370 responders, what you can see is that 95% of those clinicians that responded were still using CT for planning. And they were still using CT, and it looks like, there was an overlap between, the 34% that were using MRI. Clearly a large percentage of them were also using CT. And the main reason for that, and I'll show you when we get to some of the cases, is really for catheter reconstruction. particularly for the GYN interstitial implants or the GYN hybrid implants. In terms of, comparing CT versus MRI for planning, MRI is better at assessing tumor size, shape, height, parametral involvement, compared to clinical exam or CT imaging. And if you look at the JEC-Estro guidelines, it is kind of considered the gold standard, as CT imaging does lead a little bit to more generous target volumes. There's a paper by Viswanathan back in 2007 that really showed no significant difference in the high-risk CTV or the organs at risk from a dosimetry standpoint in patients undergoing both MRI and CT-based planning. This is really a good paper as well, which was by Dr. Potter's group in Vienna, which showed that where you don't have access to MRI the patient for simulation, you can get a diagnostic MRI ahead of time and basically end up with very similar results as if you had done MRI imaging with the implant in it themselves. The only stages where there's still a little bit of advantage to doing the MR sim itself, as opposed to doing kind of a pre-brachytherapy MRI, were 2B patients that had still significant parametral extension at the time of brachytherapy, and then the 3B patients. But pretty much, for stage 1, they found, so this is like your 1Bs, 1B2s, 1B3s, they found that there was no advantage to using MR over CT. And that actually applies to the 2A patients as well. Here's just an example of using the JEC-Estro guidelines based on our CT imaging. This is that same patient, kind of what it looks like on MRI. And this kind of really just kind of discuss a little bit about incorporating like pre-brachytherapy MRI in those situations where maybe you don't have access to an MRI for every brachytherapy implant. So if you look at the consensus statement on 3D image-guided brachytherapy planning, the two main ones, the ABS guidelines basically says that you should use either CT or MRI when feasible, essentially to prescribe to a high-risk CTV. And then, the UK guidelines mirror that, where, they're saying MR still is considered the gold standard. However, if you don't have access to an MRI, you shouldn't really delay implementation of your image-guided brachytherapy program, and that there are mechanisms in place, such as you getting an MR, a diagnostic MR prior to implant, so that you can do this all based on CT. If you look at our workflow here for most of the intracavitary hybrid patients, we'll typically get an MRI near the end of external beam brachytherapy, and then we'll, as I mentioned before, we'll get an MRI with the first and third fraction, and then, but we're using the body tone with essentially every fraction. And this is, if you look at that's basically for like the intracavitary and hybrid. If you look at our interstitial approach, really the only difference is, we treat these patients BID all the time, even prior to COVID, just to try and limit the number of interstitial implants that we have to put the patients through, as well as making sure, we're completing their entire treatment course in under 8 weeks. So we'll get a CT and an MRI with each implant, and really where the CT is most useful is really with the applicator or the catheter reconstruction, and then we're using the MRI data more for contouring the volume of the tumor itself and the organs at risk. So just wanted to go over kind of a few of our cases, so you kind of see what the images look like. So this is a recurrent endometrial or really uterine serous carcinoma who had a vaginal cuff recurrence. So originally we had tried using a multi-channel cylinder, but we're not really happy with the coverage. And so my partner actually opted to use a Venezia with the 0 centimeter length tandem and with the vaginal caps, and really essentially placed the 4 interstitial needles. And so here you can see these are actually images from the body tome from that implant itself. And this is what that isodose distribution looked like. So it actually came out to be like a really nice implant. This patient's still NED. This is a stage 2B squamous cell carcinoma of the cervix near the end of her external beam that showed some persistent disease with parametrial extension. This, you can see the body tome image on the left, and then the MR sequence on the right. And this really kind of shows you from a catheter reconstruction, at least in our hands, the importance of having CT. We found that if you're doing strictly an intracavitary with no needles, you can get by with just using the MRI. And for prostate interstitials, you could probably get by with just using the MRI, as we do a fair number of MRI-based prostate implants. But at least for the GYNs, if you're using needles, we feel more comfortable with the accuracy of reconstructing the catheters with CT. So yeah, so again, this is a Venezia hybrid implant with 4 interstitial catheters. And here you can see how that implant looked with actually really nice dosimetry coverage. This one is now a 37-year-old female with a stage 3C2 cervical cancer, and this is her MRI kind of towards the end of her external beam, which again showing residual parametrial disease. And she actually, if you look kind of towards the mesorectum, you can see like that she had disease kind of right at the peritoneal reflection, approximating the sigmoid colon. So we ended up doing a Venezia applicator. This time we used 5 catheters to kind of allow dose escalation. And this is what that implant looked like. And these are all images from the body tome. If you look at the coronal on this, as well as the sagittal, if the reconstruction from the body tome itself is better, these have been pulled into on centra, and so you get some degradation of the image on the sagittal and the coronal on those. This is kind of give you an idea what it looks like with the vaginal cylinder, so pretty standard case. And you know, in our institution, we generally tend to do most of our prostate implants under MRI-based planning because we have a research project looking at dose to neurovascular bundles, as well as to the dominant lesion, as you can kind of see here, kind of in that dark red. However, here in Florida, we do have an elderly population. A loop monitor or a pacemaker are not uncommon, and so we do have a large number of patients that are not MRI compatible. And actually in this instance, this is a patient who was like about 5'7" and pushing 400 pounds, and so we ended up just simulating them with the body tome. But what you can see here is this is an extremely large patient, and the image was just as good as I think what we would have found with our standard CT simulator in the department for the size of the patient. And this is what that implant ended up looking like. And this patient is actually an example of when you don't have access to ultrasound. So this patient had previously undergone an APR, and so there was no rectum to use an ultrasound with. And so we actually did the biopsies ourselves under CT guidance using the body tome. And then we subsequently came back and treated him. We did the whole implant strictly under CT guidance. So you can see, particularly posteriorly, it's a little bit more of a challenging implant than when you're using ultrasound, but definitely feasible. And this whole implant, the actual implant itself, took about just over an hour. So not an unreasonable amount of time, definitely a lot longer than when we're doing ultrasound guidance, but definitely feasible. And then since this patient, we've done actually another 4 patients in the same situation. And this is kind of what the dosimetry looked like on that implant. So, in conclusion, it's a pretty smooth transition to having a dedicated mobile CT unit for brachysimulation. I think it's important if you're starting a brachytherapy program, or if you have an existing brachytherapy program and you're looking at how you can improve your workflow, and definitely if you're going to make the investment to actually build a brachytherapy suite. Like, I think as a department or as a program, you kind of have to go through some self-exploration to really understand your own department's bottlenecks, whether that's access to MRI, whether that's, having enough CT simulator time, whether it's, involving anesthesia and their availability and being able to schedule around that. But it definitely helps, especially in our case, to kind of map out your workflows and look for the potential efficiencies that you can introduce into your program. And for us, having the dedicated mobile CT unit was a large part of that. I think you really have to kind of take into consideration your own geographical footprint. One of the nice features of the body tome is the fact that it's self-shielded, so it doesn't require any additional shielding in the room itself. So if you don't have a designated brachytherapy suite, but say you have a large unshielded procedure room, that it would definitely do well in that scenario. And just really give careful consideration to what is at least in your hands the optimal image modality for each of these individual brachytherapy cases to determine how you're going to integrate imaging into your workflow. And like everything else with radiation oncology, it's really requires a coordinated effort between your physics staff, whether or not you use radiation therapists in your brachytherapy program, or if you primarily use physics, the physicians, nursing, if you have your own recovery, and then of course anesthesia. Thanks for your time.